Hi, my name is Kyrie Wilson. I'm a very new postdoc at the Medical University of South Carolina. And I'm thrilled to be here today to talk about the gene therapy that we are developing for mitochondrial diseases. As we talked about, mitochondria are the powerhouses of cells and so much more. And to facilitate their many functions, they require their own DNA called mitochondrial DNA. The problem is that in aging or in certain diseases, mitochondrial DNA can acquire mutations, and this causes mitochondria to become dysfunctional in a variety of different ways. We get a little bit deeper into what mitochondrial DNA looks like. It's a circular 16.5 kilobase pair molecule that's maintained inside the mitochondria, so it's protected behind the double membrane structure, and this makes it very difficult to access with traditional gene therapies. It encodes for 13 essential mitochondrial protein subunits for the variety of the different functions, and it's replicated continuously, separately from nuclear DNA, and even in cells that are no longer replicating. The final feature of mitochondrial DNA that makes it very unique is that there are many, many copies of mitochondrial DNA in each mitochondria and cell. And because of this, damage accumulates a little bit differently than here we think of it. Most people don't think of mitochondrial DNA this way. Instead of having all of the mutations at once, mutations accumulate during stress or replicative errors. And as these mutations accumulate, you can eventually reach a disease threshold in which the damaged mitochondrial DNA is more prevalent than the healthy, and this can cause the disease. Mitochondrial DNA damage can be present in many forms: base changes, insertions, deletions, linearizations, partial deletions, partial duplications, and all of this leads to what we're generally called a balance between healthy and mutant mitochondrial DNA, or the heteroplasmy burden, which is what we think about in age-related diseases, because it's not one single mutation likely contributing to the disease. It's a variety, it's an accumulation of mutations. And so cells have some intrinsic methods to deal with DNA damage, but it is very limited. They have some minimal repair mechanisms, but as we've discussed, the most common way is selective clearance of damaged mitochondrial DNA and amplification or propagation of healthy mitochondrial DNA, but this is obviously limited. And so all of the therapies that we have right now, most of which are preclinical, fall short. Small molecule drugs may boost mitochondrial function, but they fail to fix the underlying problem. Gene therapies target only a single mutation at a time, and mitochondrial transplantation has some incredible benefits, as we've seen, but it fails to provide long-term mitochondrial DNA integration. So we've tried to come up with a solution. We said, why don't we just deliver healthy mitochondrial DNA to all of the cells to replace the damaged mitochondrial DNA? And we did this with a nanoparticle that consists of the cargo, which is mitochondrial DNA, a mitochondrial targeting molecule, rhodamine 123, and our packaging material, which is cell-penetrating peptide, or CPP, that we call RD3AD. And this RD3AD delivers cargo while facilitating protection of the mitochondrial DNA cargo, cell penetration, and endocytic escape to ensure that we reach the mitochondria. We had a few key steps in developing this prototype nanoparticle. First, we had to create it. Then we had to deliver it, prove that we could deliver this nanoparticle to the mitochondria, that it was retained long-term in the mitochondria. And when we did this, we compared the retention of mitochondrial DNA from our nanoparticle compared to mitochondrial transplantation. And then we had to validate that the mitochondrial DNA that we delivered is functional. Is it actually doing something? And our first step to create was to make the nanoparticle, and so we used atomic force microscopy, and we looked at mitochondrial DNA by itself, and we could see that we have a lot of strands. These individual strands that you can see are the mitochondrial DNA by itself. It's clumping because of the experiment. Ethanol causes DNA to clump, unfortunately. As we started to add the packaging material, RD3AD, we certainly started to see more clusters and more packaging of the mitochondrial DNA, but the DNA by itself is still stuck out. So when we continue to add even more of the peptide, we find that we're able to fully package the mitochondrial DNA into these really nice little particles with no DNA visible on the outside of the particles. They're about 150 to 200 nanometers, which is an excellent size for delivery. Our next step was to determine if we could deliver these into cells and if they reached the mitochondria. We used live cell confocal microscopy to do this. This is still images, they're a little bit easier for the presentation. So we delivered the nanoparticles. We stayed in the mitochondrial network, is shown in magenta, and we delivered the nanoparticles shown in green. We outlined the mitochondrial network, and we looked at where the nanoparticles with the mitochondrial DNA are co-localized with the mitochondria, and you can see that in red by 3 and 4 hours we have localization to the mitochondria of our nanoparticles. We confirm this with a few other methods that I'm happy to talk about afterward. Our next step was to assess the mitochondrial DNA that we're delivering, and we wanted to make sure that it was intact, that we weren't only delivering fragmented mitochondrial DNA. To do this, we use a long-range PCR assay that encompasses the entire mitochondrial DNA. It's 3 contiguous fragments and encompass that. And in healthy cells, of course, they have all 3 fragments. In these row 0 cells or mitochondrial DNA depleted cells, we see none of it. And so we used this model then. We treated row 0 cells with mitochondria by itself, or mitochondria with the targeting material, and we found after 4 weeks that there was no retention of mitochondrial DNA in these row 0 cells. But if we used either the RD3D with mitochondrial DNA, with or without the targeting material, we have retention, long-term retention of mitochondrial DNA at both 4 weeks and incredibly at 8 weeks post a single delivery to these cells. So then we went on to compare this to transplanted mitochondria, and we found that the amount of DNA when we delivered, we controlled to make sure that we're delivering mitochondria that contain about the same amount of DNA as our nanoparticles do, and we found that the DNA that was retained by the cells after 4 weeks was significantly greater, about 30 to 70 times greater than that by mitochondrial transplantation. The next step was to look at whether the DNA that we delivered produced RNA and protein, and we found that at 4 weeks post-transfer, we have an increase in both RNA and protein. And so our next step is to start moving this. So we showed, hopefully I convinced you that we created the mitochondrial DNA nanoparticles, delivered them, established the long-term retention, and validated their functionality. Our next step is to move this into more disease-relevant models, and our first indication is blindness. Blinding diseases have a very, very high impact on the patient's quality of life, and there's a large patient population. As a scientific model, and I'm a scientist, so I think this way, ocular diseases offer a direct injection to the site of damage, low leakage or off-target effects, and very measurable outcomes in disease restoration. And so I would like to acknowledge all of our collaborators. We could not do this without all of the people here and their funding sources. And invite anybody, my proposition for this is not that we have the solution, but maybe we have a solution that is complementary to what a lot of people here do. And so if you're interested in collaborating with us, please reach out to me, and my contact information is here, or I have a poster, come talk. We are happy to